Presentation by Dr. Amir Mrad, Nabota.
Okay.
Concepts
of Nabota. So, good evening, everyone. My talk is about a very safe drug compared to other things that we've talked about today. And to be honest, I feel very safe when a patient comes in asking for Botox or toxins in comparison to surgery or to even fillers. So in the past, surgery was the only path to facial rejuvenation. Unfortunately, it was invasive, it was costly, and there was a long downtime. With the advancement, this has improved dramatically from a surgery point of view. However, toxins came in and they took over a big chunk of what we can do. It's quick, it's safe, and it's reproducible. It started in 1989, where FDA approved toxins for blepharospasm and strabismus. Later on, they noticed that the wrinkles have disappeared after injecting the patients for strabismus, and then it became FDA approved for glabellar lines. Then it became a mainstream in aesthetic popularity in the 2010s. Today, it's a cultural phenomena. Like most of your friends and family that you've known, that you know, have used toxins in their lifetime. Nabota specifically was the first Asian botulinum toxin approved by the US FDA in 2019. We don't use toxins just for wrinkles. We use it for migraines, hyperhidrosis, especially in the summer nowadays, dystonias, bruxism, and also skin improvement in micro doses. It's one molecule that has that's used in different specialties. So from repair to prevention. In the past, we used to use toxins to repair patients' features and usually use it in older age. Now, with recent studies, we use it for much younger age to hopefully prevent and push back the aging in terms of wrinkles. So with your patients, and this is more applicable maybe for surgeons, but also for dermatologists and their clinics, we usually start with toxins. And then we move to injectables, and then devices, and then surgery. And we're trying to postpone surgery as much as possible. Now, with the introduction of devices, toxins, improved fillers, and collagen stimulators, this has pushed away a lot our facelifts. And patients usually start small with you, with toxins and fillers, and then they stay loyal to you and your clinic. So I'll talk about my technique, discuss before care, and this is important to all levels, I think, because some people forget, and then once a problem happens, they remember, and there's like, oh, I forgot to do this. But this has to be routine and in all your clinics and all your hands. I'll talk about my reconstitution of the toxins, and then the location and amount. This is important, and then the aftercare. So before care, there's a pre-treatment checklist. All patients have to get photos, not for your social media, not for advertisement. We use it in their patient's file for their and your safety, the follow-ups. And for at my level now, refuse photos, there's no treatment. And I advise you, I always did this, but I advise you to do that because the problematic patients who refuse the photos, there's no reason for them to refuse the photo, take the photos by their phones and keep it with them. It has to be with me. Don't trust me with their photos. They shouldn't trust me with the toxins, putting an injection into their face. Every patient we touch in the clinic, toxins, fillers, lasers, anything, have to have a consent. We are not allowed to touch another human being without a consent. So consents are crucial. And also, especially when you're starting, and you don't have your nurse or assistant in your clinic, then you have to mark yourself. You have a face and you mark on it. I'll show you in a minute. So this is a treatment checklist. You ask the patient their allergies, autoimmune diseases, pregnancy. Very important to using toxins. No toxins with pregnancy. No toxins with breast. And I push them, even if I'll get rid of the milk tonight and tomorrow. No. After you finish everything, come back. We think you're beautiful, even if you're, breastfeeding. You don't need. We accept you with your wrinkles, no problems. Blood thinners and aspirin. It's not a contraindication, but you have to know to tell the patient that she might bruise more commonly than other patients. Other medications, that's your treatment. So previous aesthetic treatment, this is extremely important. So if a patient comes in, I had my previous treatment with Dr. Sami, and she starts talking about Sami, I know she'll be talking about me negatively in 4 months. So I tried to, push it away. And I want to know what she liked and what she disliked, and why is she changing now? Why is she changing? What happened? So most commonly, she mentions a name that I don't know, so I'm not familiar with, and it's usually a ptosis or a devil's look that happened, and the patient did not correct it. So if I understand this, then I know that there was for her to change, and maybe I'll give her the treatment. About what's her main concern? Do you want to lift your eyebrow? Do you concerned about the wrinkles, the Wi-Fi? What's wrong in your face that you're with? And then the neuromodulators work, especially if the patient is the first time in our clinic. So them how it works. I tell her, I don't use any local numbing creams or anything. I just go ahead and inject her directly, and she doesn't feel pain, alhamdulillah. But I start, if it's the first time, I tell her, just let me try one. If I hurt you, I'll numb the other areas. And we go ahead, and she said, I didn't continue, and they're fine. We talk about possible adverse, and usually in toxins, and that's why it's a very safe drug, and we love it. The complications are solvable in a week's time. So the most complication I hear about is the devil's look. Or ptosis is bad, you need to live with it for a while. But if you have devil's look, or you had asymmetry, upper face or lower face, you can fix it. They come back in a week or 4 days, and you fix it. But you need to tell them that this one, and I know how to fix it. And that's it. It's the facial sheet, and you mark on it what you did to that patient, whether toxins or fillers, and the type, and you write everything. If you don't have time, you're busy, inshallah, then you get your nurse to do this for you on the computer system or writing. And this is very important for patients. So when she comes back in 4 months, if you had a retouch for the patient, did it work? Did it not? You put it in a specific line on the forehead. We'll come to that. And she had ptosis. So in the future, you know that you have to go a line above, a centimeter above your previous line. Consent, we've talked about. Photography, we've talked about. The sheet. Okay, so patient assessment. The most important in toxins is the brow size, and this is very important. I don't go with a centimeter, a finger breadth above the hairline. I go with the measurement of the forehead. So if the forehead is a normal measurement, which is around 4 to 5 centimeters, midline in it. I'll show you in a minute. But brow size is very important, and we'll get it when we go into our deep dive. We want to see if she has any muscle hyperactivity in which I would need more toxins in an area with other. Any eyelid ptosis before I treat her. I need to document this, and I need to tell her, listen, your right eye, it's ptotic a bit compared to the left eye before, and it usually shows in the photos. any facial weakness or asymmetry. Only notice it after the treatment and not before. I asked the brow, do an angry face and a partial wink to see the crow's feet. So you need to understand the dynamics between different muscles. So it's like this pull the rope game where a muscle to one side and the other muscle is pulling to one side, and you have that facial feature. So if you weaken a muscle, the other muscle will take over. We were discussing this morning cadaver in the workshop, where the doctors are telling me, what about using the toxin here or here to do this? I said, explain what muscle are you stopping and what muscle is taking over. Then I'll understand what you're saying and I can do it. But if you just tell me I'm blocking the orbicularis oculi under the brow so that I can lift the eyebrow, it doesn't make sense, because the orbicularis oculi in here is a converting muscle, is not a depressing muscle. Medially and laterally it depresses the forehead. You know how it works. Reconstitution, there are efforts to reconstitute, but the most common, I use the 4 ml of saline, and I get 2.5 cc in each spot. I don't know if this works. So this is a 1 ml syringe, so 0.1 has 2.5 units. So my dots that you see are 2.5 units each. Most dermatologists require 2.5, and the resulting 0.1 has 4 units in each. So if you want to put 2 units, you put half of that one segment. So let's go a deep dive. Here's where the forehead size. If it's a regular forehead, 4 to 5 centimeters, you see it, you don't think it's wide, it's normal. Then you divide it into half, and that you inject in. You draw the lines, medial 2/3 and lateral of the eyebrow, and that's your square, and that's the line you inject in. I don't measure my finger breadth, I don't measure a centimeter or 2 above the eyebrow. I just go with that line. That's a very safe line. If the forehead, most complications that I see are from narrow foreheads. So they're very narrow, 3 centimeters or less. And the doctor heard and he said, let's go mid. That mid is so close to the eyebrow. A short forehead, you need to go almost at the hairline. The mind that does not represent where the hair is. The muscle is the muscle, usually. So you go closer to the hairline. If it's a longer forehead, then you use 2 lines. That line and a few spots on top of it. I'll show you in a minute. So here's where you put your toxins, and there's the muscle. So if the hairline lower, the muscle is still there, and it's normal, and it's a long muscle to represent the hairline. If it's the forehead, I do another line, like 2 centimeters above it, and just do 2 dots. Each dot is 2.5 units for me. You can do 4 if you're doing the 2 ml, or you can put. It depends on how much do you want to block these wrinkles from the patient. I usually like them to have a normal expression, and this 2.5 has been serving me very well for the past 15 years. Crow's feet, again, you want to know where lateral orbital rim is, and you want to inject lateral to that at the tail of the eyebrow, at the level of the lateral canthus, and then reflecting that inferiorly, a mirror image of the top, you put that as well. And this is a 2.5 unit each as well. And if it's in where you're worried about irregularities or problems, then you can put 2 dots only, and then wait and see them in the retouch. And this is something it's a beauty about this drug, where you can see the patient later on and add or subtract to what you want. And here's the muscle. You see the muscle is very wide. Today in the cadaveric course, they were talking about another layer. So you inject here, and then you on the muscle laterally. I've never done it, but you can do that because the muscle is The muscle is huge and it'll accept it. If it didn't work, it will not. Okay? Then the glabellar area. Here you want to treat the gator muscles and the procerus. Lots of discussion this morning. Do I go deep? Do I go... In my technique, I just ask the patient to frown. Once she frowns, hold that muscle between my fingers, and then ask her to relax. And then I inject just between my fingers. It's not too deep, it's not too superficial. And just in between my fingers, I feel the muscle bending with the injection, especially in my 4 ml solution, because I have more saline in it. It's a bit painful because the muscle is stretching. It means I'm in the right muscle. I'm in the right location. You cannot block that pain. What you're putting is a cream, superficial cream, and it will not block the muscle expansion. And that means I'm in the right level. And if I want extra, I inject the tail very superficially, but with the same technique. And then the procered line, and these are all 2.5 units each. You can do your 4 units, but that's what I do. And here's your corrugator muscle, and here is your procerus. Gummy smile, lots of questions this morning. I asked the patient to smile, maximum smile, see what is the maximum level of pulling in her cheek, in her smile. And usually it's somewhere along the labial fold, but this is the area that I want to see how much is. And I inject it accordingly, usually with same dose, 2.5 units. All my dots are 2.5 units. If she comes back later on, or she has a severe gummy smile, then maybe I have 2 dots lateral to each other, but I can always stop. But you cannot go back. So I'll wait and inject her. And this is the area that you're trying to stop. You're trying to weaken this area. Weaken enzai, zygomaticus major and minor, and lip levators. So all the lip levators, and that's what you're trying to weaken. When you inject one side, you don't need to study the other side a lot, especially if she has a symmetrical smile. You just need to go precisely same level, same distance from the ala, same depth, and so it's exact mirror image. Otherwise, you'll have an asymmetry. Not biggie. She comes back and you fix it. That's the first patient I've injected. That's my nurse in Toronto with fillers and toxins. So you remove makeup, alcohol swab like crazy in both injections because that's the source. So what touches the patient is alcohol swab and then the needle. You don't put the alcohol swab and touch and then palpate with your finger and then you inject. The thing that touches the patient is the alcohol swab and then your needle or your cannula. Topical anesthesia. So I'll leave this for the next speaker. What's next? We want longer lasting formulation and medical indications, and then hopefully we can use it on younger, broader demographic, from paralysis to possibilities. Thank you very much.